Wanted to welcome everyone to tonight's talk. Thank you everyone for taking time out of your busy schedules. I think these are always very helpful patient education talks, and hopefully everyone comes out of it with something new and new information that will hopefully help you. So I know today the audience is a mixture of existing patients of Georgia Urology and new patients. So I just wanted to introduce myself. My name is Edan Shapiro. I've been at Georgia Urology for almost 8 years now. Before that, I was at Columbia University in New York City. That's where I did my training. I practice general urology, but I have a special interest in helping both men and women with bladder-based symptoms. So many of you may be identifying with some of the things that are coming up on the screen. Will I have control of my bladder? How can I go outdoors now that things are back open after COVID? Going on a job interview, going with your kids or your spouse somewhere, and just not being afraid to leave home. And I think the most important thing is that if you're feeling concerned, but maybe too embarrassed to talk about, it's important that we try to change that. Unfortunately, up to half of patients who do have urinary incontinence have never discussed it with a doctor. And I think if there's one theme of tonight's talk, it's that I would like very much to change that. So here's what we're going to be talking about tonight. This is the agenda. First, we're going to understand how the bladder works and some of the problems that may occur when the bladder does not work normally. We're going to have a little bit of an overview on overactive bladder, and then some of the treatment options that pertain to it, and also want to focus on some of the lesser known options and give you guys some more detail about some of the many ways that we can treat your bladder symptoms. And then we'll wrap up by answering questions. Just to remind everyone, if you came in late, on the bottom of your Zoom screen, there should be a Q&A box. So please feel free to ask whatever questions you want. All questions will, of course, be anonymous, and time permitting, I'd like to answer as many as I can tonight. So let's get into it. You need to know, as I mentioned before, you're not alone. This is actually our largest audience yet of the webinars that we've been doing, and I'm really excited to get to educate so many people. So overactive bladder, which is also called OAB, and I will probably use those terms interchangeably tonight, it's extremely common. It represents up to almost 40 million people in the US. So that's 1 in 6 adults have it. It's more prevalent than diabetes. If we also take into account fecal incontinence, which is a bladder issue, we're adding another 20 million people. So that's a lot of people. Now, you might be asking, if it's so common, why haven't I heard about it? And remember what I said at that first slide, there's an embarrassment issue. And sometimes what happens is people self-manage, they drink less, they wear pads, they don't go out. And at the same time, the reality is a lot of physicians may not realize that from the patient's perspective, there's an embarrassment and they don't bring it up. And then it becomes this cycle where just no one talks about it and it stays hidden. And as I want to put up here, this can often lead not just to a loss of normal socialization, but also just general poor feelings of health, reduced self-esteem, reduced confidence. So it's really important to note that incontinence is not a normal part of aging. This is not something you should assume you just have to live with. It's not something you should accept. It's not something you should ignore. And again, some of these descriptions I imagine many members of the audience will probably sound somewhat familiar. Having that, I need to go now. I can't make it to the bathroom. I can't sit through a movie without having to get up. I'm changing where I'm going. People talk about this concept of bathroom mapping. Every store they go to, patients tell me they know every single bathroom in that store. And that just sort of completely consumes their life, and it takes up brain space where they can otherwise just be enjoying what they're doing. And the bottom line is that It can be embarrassing. It can have a significant impact. But if these things are going on, it's probably your body telling you something's wrong. And I think it's important to listen to your body. Well, I'm giving a lot of obviously negative news, and I want to give you immediately some good news, which is that we will discuss tonight. There are treatments that can get you more freedom, more life, and more control. And we don't let the bladder control your life. So this is a busy slide, and I know you guys aren't physicians, and this may be new, but I want to kind of go through step by step, because as we start thinking about the bladder, as we start thinking about what's supposed to happen, what may not happen correctly, that is important to know what's going on, know the signals in your body. And it's also important when we view the different treatment options, it's important to sort of think, where in this pathway are those things happening? So to start at the very beginning, the kidneys, which in this picture are those two organs sort of in the middle, those blue organs in the middle of the body, they produce the urine. The urine drains down from the kidneys into the bladder. As the bladder fills, it sends signals to the brain. And when the bladder here is about half full, it starts stimulating the nerves. Now, the nerves in the brain then in turn signal your bladder that it's time to empty. Now, that doesn't mean it's going to happen automatically, right? Obviously, if we have to go, generally speaking, if it's not a socially appropriate time, we may be able to say, I'm going to wait, but at least we're starting to get a signal that we have to go. And I want to go just back to this box for a second, which is when the bladder is half full. That may be normal, but think about a situation where the bladder empties, you just go to the bathroom, you have a very little amount in your bladder, yet the bladder is sending signals to the brain that you have to go. So when people come in and say, I've got to go every half hour, every hour, it's not necessarily that they're making more urine. It may be that the brain is responding to a signal that's happening at a lower volume of urine that it should, and that's triggering you to have to go right away, and that's causing a lot of issues. So I think the first sort of conclusion from this slide is that the nervous system and the communication between the brain and the bladder is essential for bladder control. And what is important is sort of looking at the inverse of that, which is that when there is a communication breakdown anywhere in this pathway, that can cause serious issues. And I want to keep these points in mind as we talk about the various treatments and see how they differ from one another. I don't want to spend too much time, but as I mentioned initially, 20 million people have what's called fecal incontinence. And this is much of the same process where as your gut, in this case, as opposed to your bladder, gets full, your brain gets a signal, and it sort of creates that process. And just like with the bladder, if anything here is abnormal, you can have issues with the bowels, bowel control issues, fecal incontinence, fecal urgency. But we're going to focus on the bladder. So where do these communications come from? There are many potential causes. Sometimes it's things, what we eat, what we drink. Sometimes it could be medications we take. Sometimes it can be life events, childbirth, different health conditions. You may also have a dysfunction or an injury to the pelvic floor, and all of these may contribute. It doesn't have to be one of these, but these are sort of the main players that are going to influence how the bladder may start acting abnormally. So in general, there are 3 common bladder control problems. And I want to just, before we even talk about the 3, I want to define incontinence, and I want to just say sort of my definition. I think the most broad definition is incontinence is any involuntary loss of urine. We're talking about urine incontinence now. So basically a loss of urine when you don't want it to happen. So we're going to look at each of these in turn, but the main focus is going to be on this 3rd type, which is overactive bladder, or OAB, that can be in the absence of incontinence. So you could be dry, but just go have an overactive bladder or with incontinence. So just briefly touching on the other ones, stress incontinence. This is the loss of urine during physical activities, laughing, sneezing, dancing, going to a gym class and having a leak. Generally, it's due to a weakened muscle system. So the muscles that normally surround the tube, the urethra that goes from the bladder out may be weakened. And therefore, anytime there's a pressure squeezing the bladder, you may have an involuntary loss of urine. This sort of incontinence is generally requiring either exercises, Kegels, or usually surgery for definitive correction. Urinary retention. This is a situation either where you as a patient can't tell the bladder is full, or you know the bladder is full, but for whatever reason, you're not able to empty your bladder. That may either be due to a physical blockage, an obstruction from a scar, from something blocking, or it could just be that the muscles that control the bladder, they're getting the right signal, but they're just not able to squeeze. And that would be sort of obstructive or non-obstructive retention. But getting to the heart of the matter, OAB, so overactive bladder. So it's important that everyone recognizes that overactive bladder is not defining of a specific disease process. It's not talking about a specific etiology. Really, it's a descriptor of a constellation or a set of symptoms. And there's both urge incontinence, which again is having the urge part is you're sitting, you're watching TV, you suddenly stand up, bam, it hits you, you've got to go to the bathroom right away. That's the first thing on your mind. And urge incontinence is where you may leak before you can make it. But the other variety is just urgency frequency, which there's a lot of overlap here. This may be going frequently during the day, going many times at night, feeling like your bladder's not emptying. As I mentioned before, your bladder empties, it keeps filling, and your brain keeps getting these signals and having these uncontrolled urges to go, even if it doesn't necessarily result in leakage. And it's the job of me or your urologist, the provider, basically, to work through these symptoms and sort of help you as the patient figure out what therapy will fit your need. So there are a number of steps involved in that process in finding the best treatment. And like everything, after you make a diagnosis, there is a continuum. And conservative treatments more on the left, that would be the lifestyle changes. And I labeled them here, first, second, and third. But my point in just giving these terms is that you can come anywhere in this process. And I think it's important to think of it as a process. I don't want to get into the details here, but at Georgia Urology, we've sort of developed this comprehensive overactive bladder treatment pathway. And I think the visual of having a pathway is important for patients because you can start wherever you want. And some patients say, I would do anything to avoid a medication, to avoid a procedure. And some patients say, I don't mind taking pills every day. And it's just important to know also that even if you start at the beginning, we can help you go, as it's important to go to some of these advanced therapies. So we try to have every patient sort of follow this general guideline. Well, let's talk about what I termed number one. So the first thing here, this is lifestyle changes. And these are simple changes you can make. These are things that are obviously free, don't require a provider, diet, exercise, not having caffeine, not having some of the known bladder irritants. It could involve bladder retraining. Biofeedback is one example, but the idea is even if your brain is getting a signal from the bladder that it's full, you can sort of do different techniques that are called urge suppression techniques. So your brain gets the signal, but then your brain is not necessarily responding immediately, and you sort of learn how to spread out those voids. Now, obviously, this doesn't work for everyone, but it's important that you can do these additively. You can do this in addition to something else. Something that I always talk to my patients about is pelvic floor muscle therapy. This is certainly I think, a widely underutilized option. And this is not Kegels. This is actually learning sometimes to relax the muscles that support the bladder in order to improve your overactive bladder symptoms. So going on to number 2, if either lifestyle changes just aren't something that you want to do, or it's something that is not working, you get to pills. And these can oftentimes control symptoms, and many times we start with pills. But it's important to identify there are some drawbacks. First and foremost, these are things that need to be taken every day. It's not a week-long course that then resolves the bladder symptoms. These are things that are taken chronically. And it's important to recognize that there could be side effects. I listed some of them: dry mouth, dry eyes, vision changes, constipation. And some of this is obviously why we know, and we know this from our own patients, from hearing, and just from studying big data sets, that a vast majority of people ultimately stop the medications for a number of reasons, whether they just don't like taking the pills, whether it's a pill that requires twice-a-day administration and that becomes cumbersome in their life, or just because they have a side effect. One last point I do want to mention is that a recent large study funded by the National Institute of Aging showed that, I'm going to say, elderly patients, whatever that means, who take anticholinergics. Anticholinergics are the main category of medications for overactive bladder, may be at a greater risk of developing dementia. That's the quote. So I think it's also important not just that there is dry eyes, dry mouth, but some of these may have cognitive implications, especially when used in combination with some other pills. And this is just showing again that, patient dissatisfaction, that a lot of patients may not return after getting a trial, and first appointment, second appointment, third appointment, we see a drop off if we're not giving them the tools to say, if it works, great, but if it doesn't work, what else is out there? And that brings us now to the advanced therapies. I want to differentiate. I use the word advanced here, but I do want to differentiate advanced from invasive. These are not necessarily invasive. These are often office-based procedures. These do not require a major surgery. They do not necessarily require general anesthesia. So we say advanced, but don't in your mind read that as necessarily more invasive. And there are two main categories of advanced therapies. And the first is Botox, which is an injected medication. And the second is sacral neuromodulation. And we're going to go over the trade-offs because there are trade-offs for each. These are both considered third-line options, and they both work well for most patients. But I think it's important to know what the trade-offs are when you're considering these. So the first one is Botox. Just like medications, these work at the bladder muscle level. This is the same Botox that people use cosmetically or for headaches. It's a medication that gets injected in the office setting through a camera that goes directly, a telescope, into the bladder, and it gets injected directly into the bladder muscle, and it works to paralyze the muscle. So like the medication, this is the target here is not the communication between the brain and the bladder, but it's really on the bladder muscle itself. And one of the risks of using Botox, again, the advantage is that it's in the office, but risks are possible risk of infection, possible need to self-catheterize. The reason, just so we're clear about that, is there's a set dose, and for some patients, if it works to make the bladder too sleepy, if you will, where it prevents the leakage episodes, the urge, the frequency, but now it also doesn't allow you to empty well, you may temporarily need to have a catheter in or catheterize yourself. And the risk of infection, those are about 5 to 7%, I think is quoted. And also, it's important that this is not a one and done. This does not get to the root problem. This is something which needs to be repeated often every 6 months or so. And because of that reason, that it needs to be repeated, we know that oftentimes about half the patients stop after 2 treatments. Now, granted, some of it may be that it's not working what they want, may be giving side effects, but it also may just be the annoyance and the inconvenience of needing to come in every 6 months for the procedure. This is now the second category. So we talked about Botox. This is now talking about neuromodulation. And this is neuromodulation, which is working on the ankle. I show a picture on the top right there of an ankle with an acupuncture needle. And on the bottom right, I show a picture of a nerve, because you may be looking at this and saying, well, what does the ankle have anything to do with the bladder? And the reason is that the nerve that helps the brain and bladder signal, which I'm going to put my mouse up here. I hope this works. So the nerve that comes here from the spinal cord and goes to the bladder also has a branch that goes all the way down the back of the leg and near the ankle. And the idea here is that if you can stimulate the nerve, you don't necessarily need to stimulate it way up here. You can stimulate it by the ankle. This is something which is done in the office. It is safe, it's effective. I say minimally invasive. This is probably the least invasive option, because it is literally a 30-minute in-office procedure with an acupuncture needle. The problem is it is also pretty onerous in terms of your schedule. So this requires a weekly session for up to 12 weeks. And if it works, you move on to monthly maintenance. So this is appropriate for patients who want it, but a lot of patients either don't like the schedule or just don't like having to come in and sit for 30 minutes with a needle going in the ankle. So this moves to the other form of neuromodulation, which I would say is the more common form. And this is the sacral neuromodulation, but this is impacting it directly where it's coming out of the back of the spinal cord. Now, this is something which, unlike medication, unlike Botox, really works at what may be the core problem that's going on, which is to say that it works by fixing the communication. And the mechanism that is believed to be how this works is, in order to sort of get rid of what I would call background noise. So just signals that are happening that you don't want to happen, that are coming from the bladder up to the brain. In order to mask those, this device gives a steady, gentle stimulation, not that you're feeling it, but it gives a constant stimulation to the nerve. So it sort of has the nerve tuned out for that abnormal signal, and it's able to just respond when it is supposed to. And this is something that comes both like a pacemaker for the heart. There's a battery component as well as a implantable wire. This is all under the skin. It comes both in a recharge-free and rechargeable, just to show you a sense of the size and what it looks like on the right side. So this bigger one is the recharge-free. That lasts anywhere, depending on how you're using it, from 9 to 12, I mean, even up to 15 years. And also, just to mention, if it dies in 15 years, changing it can be done in the office setting. So it's not like you need to start from scratch. You have the rechargeable, which is significantly smaller, but and it lasts longer, but does require you to recharge. And something else that's unique, and I really want to focus on, that is specifically to the INTERSTIM or the sacral neuromodulation, which is not true for Botox and not even true, I guess, for medicine, which is this is really the only therapy that lets you try it first. That is an office evaluation. This is something that's done under local anesthesia. So if this was an appropriate treatment and something that you ultimately thought would be what you were looking for your symptoms, we would schedule you in the office. You would be laying on your stomach on a bed. We would numb the skin, and a small, it says here, lead, which is really a thin wire like a hair, is inserted into the upper part of the buttock, which is where that nerve comes out of. It gets attached to an external device, which is shown in the picture, worn as like a belt. And this is anywhere from 3 to 4 to 5 days, regardless of the outcome. It just gets pulled out in the office and no bandage needed. There's no sutures, there's no stitches to be removed. And generally patients are feeling by the second day after we do this, a significant improvement. And again, improvement here we're defining as a 50% decrease. So certainly up to a third of patients may be completely dry, but if you're waking up 5 times a night and you go down to 1 to 2, most people are going to feel like that is a pretty significant clinical impact, even if it doesn't mean that they are completely dry 100% of the time. So this is a very nice option to say, would regulating the nerve system, would helping the brain and the bladder communicate better and more efficiently and more effectively, would that give me symptoms? And if the answer is yes, then obviously you can move on to the implant if you want. So we know that sacral neuromodulation is both safe and effective. There've been, anywhere between 400 and 500,000 people that are worldwide who have had the therapy. Very high success rate. So here, 84, 85% who are satisfied. We know that it is generally thought of as to give better results than medication. And about 3/4 of people, are happy and have success, as opposed to almost half patients who have medication. One of the things that has been questions in the past and that patients often ask about this device, will it set off metal detectors? No, we obviously do give you a card if you're in the airport or if you have any issues. But the bigger issue is MRI compatibility. And with the newer models, with the one we're doing, these are completely safe for full body scans. Both 1.5 and 3, those are the powers of the magnet that's used. So those are the 2 types of MRIs that are done. And something that is becoming more relevant for this is that there is emerging data that this sort of technology, not the MRI safe, but the ability to modulate the nerves with the INTERSTIM device, has success not just for overactive bladder because of bladder issues, but also patients with neurologic conditions that impact the bladder. And that can be a patient after a stroke, that can be a patient after a spinal cord issue or Parkinson's disease. And those patients are having oftentimes bladder symptoms, but they often need somewhat frequent scans with MRIs. So this is nice to be able to know that you can have this and you don't need to necessarily take it out or do anything special in order to have an MRI scan. So what makes someone a good candidate for the INTERSTIM system? So obviously, if you have significant overactive bladder symptoms, if you have fecal incontinence, if you've tried lifestyle changes, you've tried medication, either they don't work for you, and that means because they have an intolerable side effect, or they don't work for you because you don't want to take a med every day, and you don't want to have to go to a physical therapist, then this is something to know. And it's also most important is that if you're not getting sort of the relief that you want, this may be good.